Chapter 10, Bronchodilator Responsiveness Testing. So the outline of this chapter includes the definition, the aim, the indications and contraindications to bronchodilator responsiveness testing. We'll also look at how to prepare for the test, how to assemble and disassemble the equipment for the actual bronchodilator administration itself. We're going to talk about conducting the pre and post bronchodilator spirometry test, evaluate the bronchodilator responsiveness test result, and then record the bronchodilator responsiveness test result. So the educational aims of this chapter are to define bronchodilator responsiveness testing, to list the aims, to list the indications and contraindications of bronchodilator responsiveness testing, prepare for the bronchodilator administration of the actual bronchodilator itself, assemble and disassemble the equipment, conduct the pre and post spirometry, evaluate and record the test results. Okay, so the definition of a bronchodilator responsiveness test is very simply spirometry performed before and after the administration of a bronchodilator. The aim is to make a diagnosis, to determine improvement in lung function with treatment, and then to determine change in lung function in a response to a bronchodilator itself. So the reason why we would do it, the indications are to make a diagnosis, determine improvement in lung function with treatment, determine change in lung function in response to bronchodilators. And please note that when you are doing spirometry for diagnostic reasons, the very first one that you do when you see a patient for the very first time is a pre and post bronchodilator responsiveness test. Thereafter, you can just do a straightforward baseline spirometry without the bronchodilator responsiveness testing. And you should monitor lung function by serial spirometry, especially in patients with obstructive lung disease. But it may be more useful to use the post-bronchodilator test result to actually do that monitoring of the lung disease over time. Contraindications for bronchodilator responsiveness testing are any risks involved with the administration of the bronchodilator itself. So we know that the risk of a single dose of a bronchodilator is very small. The decision to withhold medication before the test, in other words, long-acting or short-acting bronchodilators, is a clinical one and should be determined by the person who is actually ordering the test for the person. The child or child's parent or caregiver should be reminded about the withholding of medications, and those instructions must definitely be given way before the test. So, washout times for medication prior to the bronchodilator responsiveness test. For short-acting beta-2s, for example, salbutamol, you should at least have 4 to 6 hours washout. So they mustn't have taken that drug in the last 4 to 6 hours. Short-acting muscarinic antagonists, for example, ipratropium bromide, that's 12-hour washout time. Long-acting beta-2 agonists, so for example, formoterol, salmeterol, including the combination inhalers, or twice daily preparations, those you need a 24-hour washout time. Ultra-LABAs, so those are things like indacterol, vilanterol, olodaterol, all of those 36 hours. And lastly, long-acting muscarinic antagonists, for example, tiotropium, umeclidinium, aclidinium, or glycopyrronium, or once daily preparations. That was quite a mouthful. And please note that inhaled corticosteroids and leukotriene modifiers need not to be withheld. At the test, it's important to document what medication, the type, the dosage, and when it was last taken prior to the testing is documented. You need to make sure that you document that very carefully so that the person interpreting the test does so understanding what medications the person might have taken on the day prior to testing. So if medication was testing, very clearly you need to record the name, the dosage, the time of the last administration, and any medication that may alter lung function, and particularly bronchodilator medication. In terms of conducting the test, you do the usual. You conduct your baseline spirometry. You make sure that you have a minimum of 3 acceptable and 2 repeatable tests. You explain the procedure to the child and to the caregiver. You explain about the possible effects of the bronchodilator medication that you are going to give them. For example, that they might have a slightly fast heartbeat, a tachycardia, and that usually that might be very short-lived, or it might not happen at all. And then you need to make sure that the washout timeframes for the particular medications have been adhered to. So you conduct your baseline spiro, as I've just described. You then administer the bronchodilator. So every facility that conducts a bronchodilator responsiveness test must have a written protocol for conducting the test, and the bronchodilator is administered in the dose and by the method specified in that protocol. So there are two main ways to administer the medication, and the first one is using a metered dose inhaler and spacer device. And there is a standard operating procedure for that, which can be taken from the ATS ERS 2019 update to spirometry from the data supplement. So the bronchodilator drug you're going to give is salbutamol through a metered dose inhaler, 100 micrograms at a time. So each puff is 100 micrograms. So 400 micrograms is delivered in 4 metered doses, 1 dose at a time. So 100 micrograms at a time. So how the patient will actually take it is after a gentle and complete expiration, you actuate the metered dose inhaler. The child inhales it through the holding chamber. The breath is held for 5 to 10 seconds before the patient exhales. And 4 separate doses must be delivered at 30-second intervals. If anyone has coordination concerns, a single metered dose inhaler actuation of salbutamol can be inhaled over 4 tidal breaths. So in other words, you can keep the spacer in the mouth, you can spray it in, and the patient just breathes in and out at least 4 times to make sure that they've got the full dose of medication inside them. If the child is very small, you can use a face mask instead of the mouth biting over the spacer device. And all of this can be seen in the practical sessions, which have been recorded, showing how to administer that bronchodilator. Then you wait at least 15 minutes before you conduct your post-bronchodilator spirometry testing. If you are using a jet nebulizer to administer the bronchodilator, again, you will use salbutamol, 5 milligrams in a little nebule. So the bronchodilator is administered using the jet nebulizer. The airflow to the nebulizer should be in the range of 6 to 10 liters per minute with an operating pressure of 50 psi, which is about 345 kilopascals. Nebulizer delivery may be either through a mouthpiece or through a face mask. Nose clips are optional, and you instruct the child to breathe normally in and out with periodic deep breaths while comfortably seated and upright until the nebulization is complete, which usually takes around about 10 minutes. Instruct the patient to breathe in only through their mouth and to keep the nebulizer vertical. So don't let them bring it forward like this. You want it to stay upright. If the child is unlikely or unable to follow instructions, you need to monitor them throughout. So you need to pay very close attention and make sure that they are holding it upright, not spilling any of it, and are inhaling nice deep breaths so that you can be sure that they have all the medication they need. When the nebulizer starts to splutter, very little additional drug is inhaled and nebulization can be stopped. So then again, you wait at least 15 minutes before you conduct your post-bronchodilator tests. So you need to be sure that your operators are trained in the administration of the bronchodilator in both the different ways that I've just spoken about. The facilities using the nebulizers must be aware that each different nebulizer has different bronchodilator doses and delivery times. So you need to follow your manufacturer's instructions, the manual for that nebulizer, to get your dosage and your time of administration correct. So, as I said, after 15 to 20 minutes of administering the bronchodilator, you then conduct your next 3 acceptable and repeatable blows. You ask the patient to then remove their mouthpiece, put it into the biohazardous waste, wash hands, and the operator washes their hands, and then wipes the spirometer down with a disinfectant wipe, and you've completed the tests. At this point, you then need to get to evaluating and recording your test results. So remember that you need to make it very clear on the test report itself what type of drug you gave for bronchodilating, what kind of drug, the dosage, and the method of administration. And then you can store the results afterwards. In terms of looking after your spacer device and washing it, you need to disassemble the spacer after the last dose has been administered. You need to soak all the parts into a sterilizing solution for 15 to 20 minutes and then remove them from the sterilizer. Rinse them with clean water, shake off the water on each and every one of the parts. Do not rinse it or rub it dry, just leave it there then to dry overnight. And then you can reassemble the parts the next day or when you're ready for your next patient. And make sure that the valve is not stuck. So now, in terms of evaluating the bronchodilator response, the FEV1 is the preferred measurement for assessing reversibility because it is so reliable. So when the FEV1 or FVC changes by more than 12% in younger children or equal to or greater than 12% and 200 mils in older children, the reversibility test is positive. Increases in FEV1 that are below 12% but are close to these numbers, for example, maybe 8% and 150 mils or something like that, that can represent normal variability and the test would then be negative. A bronchodilator responsiveness test is negative when the FEV1 changes by less than 12% in younger children and less than 12% and 200 mils in older children. So a negative bronchodilator response on an individual test does not exclude the diagnosis of asthma, as it is a variable disease. And similarly, a bronchodilator response with a normal spirometry does not always suggest asthma. So some of the limitations that you need to take into account is that failure to demonstrate a significant response to one single dose of a bronchodilator on one occasion does not mean that the child will not respond differently on a different occasion. So results from children that have not performed acceptable and repeatable baseline Spiro should be interpreted with caution because often in these instances, the child doesn't do as well as they could, giving you a little bit of a sub-maximal or a substandard result on the pre-test, but by then they've had a little bit of practice and they do better on the post-test. So watch out for that when you're interpreting these test results. And then a poor bronchodilator response may be related to poor inspiratory effort or inhalation technique. So make sure that you try and follow these standard operating procedures to the very best that you can. So in the following pages, what you'll see is some bronchodilator responsiveness tests. These are examples that you can then work on to see if they are positive or negative. So let's just take a look at example 1. What you would look for is, first of all, to make sure that the curves that you have pre and post bronchodilator are acceptable and repeatable. So if I have a good look on this actual test report, I can only see the best of all the blows that was done pre and the best in the blue on the flow volume graph. And I can see the best of the test that was done on the post bronchodilator, which is the red test. Those two blows are acceptable. The FEV1 pre is an actual value of 0.93, and after the bronchodilator, it's 1.05. This is a difference of 120 mils and 13%. So would this be a positive or negative test result? Let's look at the age of the child. So the child is 4 years old. That means that they've got more than 12% change pre and post bronchodilator. So this would be a positive bronchodilator response. Is it a complete or incomplete response? Okay, so complete reversibility is when a test that is maybe obstructive on the pre-test then becomes normal on the post-test. Now, this one has normalized. So when I look at the results, the Z-score is 0.98 for the FVC post, minus 0.84 on the FEV1 post, and 0.22 Z-scores on the FEV1 FVC ratio. So this test is completely normalized, and therefore we have a positive bronchodilator response and complete reversibility. Let's look at example 2. Again, what do? You look at your graphs, and what I can see is that my pre and my post test are acceptable, and you would have checked the repeatability of the tests before you go forward, and I can't read that off this report. The FEV1 pre is 1.70 liters, which is a Z-score of 0.65, and post bronchodilator it's 1.93, which is a Z-score of 1.78. There is a 13% improvement and 230 mils. The child is 5 years old, so this is a positive, complete bronchodilator response. Example number 3, if we look at the graphs, both the best test pre and the best test post look acceptable. And when I look at the FEV1 pre, 1.86, a Z-score of minus 0.21, post 2.08 and a Z-score of 0.88, there is 11% improvement and 1.86 to 2.06, sorry, not 8, that is 200 mils. So we have a change of 200 mils and 11% on an 8-year-old child. Is the test positive or negative? If you're taking it literally, remember we need more than 12%. So this is a very, very borderline result. It would have to be categorized as the negative bronchodilator response, but you would interpret that with caution, understanding that you're at the very borderline there. And depending on what you're looking for, you would then make your treatment decision going forward. In example 4, both curves are absolutely perfect from start to finish, so that's your best pre and your best post. The FEV1 pre is 2.55, Z-score 2.08, and post 2.52 and a Z-score of 1.96. So you actually have no change, a slight negative change, minus 1% on the FEV1. There's absolutely no change before and after the bronchodilator. This is a negative bronchodilator responsiveness test. And then lastly, example number 5. If I look at my tests, they look pretty acceptable, both pre and post. My FEV1 pre is 2.04, which is a Z-score of minus 1.44, and post 2.51, Z-score of 0.25. There's a 23% difference and 470 mils. This is a very positive bronchodilator responsiveness test. So that brings us to the end of bronchodilator responsiveness testing and indeed to the end of the manual. So thank you for your attention, and let's go on to the practical exercises.